Hello and welcome to Navigate Cancer. My name is Teresa Ferreira, and our guest today is Cristina Saura. She's a leading oncologist and international researcher in the field of breast cancer. She's the head of the breast cancer unit within the medical oncology department at Vall d'Hebron Hospital in Barcelona, and also principal investigator of the breast cancer and melanoma group at the Institute of Oncology. I met Cristina many years ago, and since then we have collaborated on a number of different projects, me as a patient advocate and her as a leading oncologist, deeply committed to improving the lives of people affected by cancer. Over the years, I've had the privilege of seeing not only her scientific excellence, but also her humanity and dedication to patients. In this episode, we will explore the human side of navigating cancer from the oncologist perspective, how they support patients in their journey from a place of choice, empowerment, and agency. Hi, Cristina. Thank you for being here. It's really an honor to have you in my podcast.
Thank you, Teresa, for the invitation and also for your kind words in the introduction. It's a pleasure. We've been talking and following us together through life and through different initiatives. And it's a pleasure to see that you are growing and to see this project becoming a reality. So congratulations for that.
Thank you. Thank you very much. One of the reasons why I wanted to have you in this program is because I remember once when we were in a call of the steering committee of one of the clinical trials, of the positive trial. And I remember we were discussing options to move forward with it and the different choices that we could offer to the patients. And I remember how you said, at the end of the day, it is the patient who chooses. It's not really up to us, no matter what we offer. It is up to them. Could you elaborate on that? I remember that it touched me like, wow, I wasn't really aware, that oncologists would, embrace that point of view.
Yeah, that's true. And it's becoming more and more common that we are following patients' life, and sometimes we recommend treatments based on statistics. And at the end of the day, we have to explain patients medical recommendation based on statistics, but not in specific numbers or a specific reality. So it's very easy for me. Sometimes I explain to the patients, when you have a patient in front of you with a high risk of relapse, it's very easy to recommend chemotherapy with a lot of safety of adverse events. It's very easy because you know that the threshold or the likelihood of relapse is very high, and it's more easy for you to recommend or to make a strong recommendation about the decision. In other specific areas, for those patients that have a low risk of relapse, or when we are discussing with patients, for example, issues related with fertility, that it's the case in the positive trial, sometimes we have to manage risk in life. We can explain to patients the risk of relapse, but we have to deal with a lot of uncertainties in life. And at the end of the day, we can explain to patients the statistics, and based on that, we can explain the different ways to follow, and they have to choose. That's life. I will be there for any decision that the patient will take, and it's something that I normally explain to them, because sometimes they feel that if they are not following your recommendations, they will lose the connection with the oncologist, and this is not the case. I will be there for any decision that they may take, but at the end of the day, it's the life of the patient. The patient is who needs to decide what to do.
Yeah, and it's really amazing that you can offer them to be there and support them, no matter what they decide. Because as you're saying, normally, well, I remember me as a patient, and I remember my oncologist saying the same thing: whatever you choose, well, I will be with you. And it makes such a difference. It makes such a difference.
Yeah, definitely. And perhaps in Spain, that it's the country where I work, in Spain, we are moving from a very paternalist oncology to a more free oncology, or a more recommendation-based oncology. And I think that it's very important, because if you have an infection, it's very easy to recommend a patient that you need to take an antibiotic. But in oncology, the issue is very different. We are making recommendation based on statistics, but each patient can interpret that. And I feel strongly that we need to share the recommendations to make a clear advice or a clear path of our recommendation. But said that, any decision that the patient may take, it's the best if it's the best for the patient.
Yeah, and I guess, and please feel free not to answer to this question if you find it too personal. I guess it's easier to let them choose, let the patients choose when it's something about fertility and you see that it's clear that, yeah, they have different options. That if it's something about treatment itself, when you see that they might deny treatment, when you see that the need is so clear, how do you handle that?
If you have a strong recommendation, or for example, a patient with a high risk of relapse, where you really know that not receiving a treatment, it will be harmful for the patient, you are more strong on that recommendation. And you explain, for example, that you have the opportunity to be cured now. And perhaps if you are not receiving the treatment, is very likely to have a relapse and you can die from that relapse. So you have to do that. But at the end of the day, the patient is who chooses. For those patients with metastatic disease, we don't have the same evidence at the beginning of the disease. So when we decide the first line of treatment or the second line, the evidence is very clear. We can share with the patients the statistics about the benefit that we expect of a specific treatment in that situation. So we can say without treatment, the disease will progress, let's say in 3 months. And if you receive this specific treatment, the benefit that we expect, it's, let's say, 2 years with the disease under control. And this is an argument that for most of the patients is enough to follow your recommendation. As you are moving forward in the path of treatment of the disease, for those patients with metastatic disease, the evidence is less clear. And for those patients that received sometimes 5, 6, or 7 lines of therapy, they ask or you try to explain the patients the potential benefit and the risk derived of a specific treatment, and it's more difficult to explain, and the uncertainties increases a lot. And I remember, for example, a patient in my clinic, her name was Maria, came to the clinic with a metastatic breast cancer for, I would say, 5 or 6 years. And she always discussed with me that she really wanted to avoid alopecia. And during that different decision-taking moments during the metastatic disease, she was discussing with me the same thing. I prefer the option of treatment that does not cause alopecia for me because this is very important. And at some point, we arrive to the decision-taking point that the treatments that could derive benefit, all of them causes alopecia. And she said, you know my decision. I am not going to take any treatment that causes alopecia. And then at that moment, we stopped active treatment, and she continued until at the end of life with palliative care, but she decided not to receive any treatment with alopecia. And it was fantastic. It was a fantastic journey because she received 5 or 6 years of treatment. I don't remember exactly. She had an excellent quality of life. She decided at different points the priorities, and at the end of life, she was happy. She enjoyed life. She had quality of life. I follow the decisions or the desires of the patient. And it's not about me. The story is about the patient. I explained very well that other options were available at the time, but she denied to receive those treatments.
Thank you for sharing that example because it's really a great example of someone who takes control over their treatment and their life and who are aware of the consequences and still they kind of define their own journey, as you're saying. And I also love what you're saying about her journey as a beautiful journey, as fantastic journey. And yes, it has eventually, but she chose how to. And for me, and also in my experience working with the people with cancer, for me, that's the key, that they know that given the situation they are living at that certain moment in life, how do they want to go through it?
Yeah, definitely. I think I always try to imagine myself dealing with cancer, and I don't know how I will face a diagnostic of breast cancer. And I'm very aware about one each of 8 women will suffer a breast cancer through life. But definitely, I have different patients in my mind that with their attitude and their decisions for sure will help me go through the way better. I try to help. I'll try to be there for them, trying to help on the best decisions to take. Said that, I'm very strong with those patients that are denying to receive treatment that I really think that they should receive. If the patient does not want to receive the treatment, I will follow the patient. And I try to at least ensure that they are understanding the consequences of the decision that they are taking, and if they are sure after discussing 2 or 3 times that option, if they are sure about the decision and they are in the capability of taking that decision, we follow at the end of the day the decision that the patient takes.
Yeah, it must also be challenging because you have your Hippocratic oath, right? When you say that you commit to saving lives and helping patients. So accepting that someone is refusing treatment and letting themselves die eventually must be challenging for you.
Yes, definitely. I try to be sure that the patient can take that decision, because there are sometimes psychiatric pathologies that may prevent the patient to take the right decisions. But at the end of the day, if the patient decides not to receive that treatment, the medical history or the medical report is also a legal document for us as doctors. And we write that we discuss with the patient, that we ensure that we are explaining the consequences of that decision. Sometimes the patient signs the informed consent form saying that she's not willing to receive the treatment in that situations of curative setting or curative treatment.
Yeah, I see. And what if it's the other way around? What do you do when you have a patient that totally gives in and relies on you to decide? Because you know that here we talk a lot about empowering patients, about what an empowered patient is, how you own your journey, how you make your choices, how sometimes if you are not the one making your choices, the consequences can be a lot harder to swallow and accept than when it is you really considering what could happen. So what do you do in those cases when someone says, you decide?
I can decide, definitely. I have in my mind the data about efficacy and toxicity. I feel honored when I feel that trust in us, and it's very common. So in Spain, we are still in that kind of model of trusting the physicians a lot. So we still are in most cases in that situation where the patients trust us a lot. Most of them follow our recommendations, and some of them are not willing to receive a lot of information. And you try to explain the adverse events or the efficacy. They say, no, thank you. Go ahead. Let me know what are you going to do if I was your mother or your sister, and that's it. It's what I will do. In that case, anyway, even they are going to accept my recommendation. I explain the efficacy that we may expect of the treatment. I explain also very well the safety concerns or the potential adverse events that the patient may suffer. And with that, if the patient confirms that she's willing to receive the treatment, we move forward, and that's it.
Yeah. And what do you do when you have a patient who comes to you asking for a second opinion and tell you that their oncologist, their primary oncologist, is not allowing them to decide? And I'm thinking now about the positive trial. The positive trial, for those who are listening, is a trial where we, and I say we because we were part of the steering committee, both me as a patient advocate and Christine as an oncologist, lead oncologist. And we were evaluating whether it was safe to become pregnant, get pregnant, and be a mother after breast cancer. So what do you do if someone comes to you asking for this second opinion and telling you, my oncologist is not allowing me to have a baby? How do you handle that? What do you do?
It's quite common. It's quite common because I would say that some oncologists are not interested in fertility issues, and they feel that the patients are so lucky to survive to a breast cancer, and they understand the fertility like something that it's not key for them. As a woman, and it's very close to my heart, the issue of breast cancer and pregnancy-related issues. For me, it's quite important. If you are cured and you still are willing to become a mother, for me, I understand that it's very important, or may be very important. So I try to be very sensitive to this issue. And for that reason, I became part of that international steering committee trial trying to address this question. And we did. And we were able to recruit more than 500 women in that situation. And now the community has prospective data collected saying that there is no harm if you became pregnant after being cured of a breast cancer with specific conditions of the treatment received before and the stage of the disease and specific conditions. Anyway, I receive patients that has been advised by their oncologist not to become pregnant in scenarios where the positive trial gives us evidence of not being harmful. In that situation, what I try to explain is that you need to be connected with your oncologist and you need to be able to discuss these kind of topics. And my recommendation is that if your oncologist is not giving you the feedback or the advice that you need, you always can change the physician in charge of you in the same hospital, in other hospital, but you need to be able to discuss with your patients the key issues for you in your life, that it's not only survival issues, it's also topics related with survivorship.
Yeah. And that implies seeing the patient as a person with a complexity that makes probably everything a lot more complex than treating them as someone who has cancer.
Definitely. And I always try to explain that 20 years ago, the main issue for the oncology community, it was the survival of the patient. Now, in 2026, the overall survival of patients diagnosed with breast cancer, at least in Spain, is beyond 85%. So we are in a situation of curing most of the patients that have a diagnosis at some point of breast cancer. So we are in the situation of start to hear and to consider other issues related with breast cancer. I think that the survival issues are becoming more and more important, and quality of life, for example, it became a need or a recommendation that the regulatory agencies are obligating to the industry to collect in clinical trials. So it's not only about cure patients, it's also starting to consider the quality of life issues. And quality of life may mean that perhaps two treatments that are equally effective, the one that it's better tolerated, it's better for the patients. The quality of life may consider survivorship issues related with fertility, related with chemo brain, related with a lot of things that may derive of the treatment received previously to cure cancer. So we are starting to assess these issues and are, I would say, today important to decide the treatments that we are offering the patients.
I love to hear that, really, because more and more quality of life counts, and what the patient, what the person wants is also important, and leaving their decisions and your decisions. I remember actually in my own case that at some point I wanted to be a mom. And funny enough, my oncologist supported me. But then, because I was launching a book and I was with my belly going to all these events, I remember people telling me, "How dare you? You're going to have a baby and leave him orphan? How can you be so selfish?" It was devastating how people can give their opinion and judge so freely. So it's even better what you're doing, and the positive trial, and how you are changing the way we understand cancer and the way we understand people with cancer. And that's...
Yeah, of course, in oncology, we are starting to build that kind of clinical trials. These kind of trials are not of interest from the industry, so we need academic groups and oncologists with this kind of worries. We need to work together to create or to generate the evidence to inform patients about this kind of decisions. For me, the key issue now is how to measure the quality of life, because it's not easy. We do have questionnaires, validated questionnaires that are theoretically collecting information about quality of life, but we also recognize that the information that we are collecting today, it's not enough, or it's not the best way to collect that quality of life that, as you mentioned before, is considering the person as a whole. So we are trying to work with new tools, with digital tools, with different kind of measurements that may collect that important information that we recognize today that it's not perfect yet, but we are working on that.
That sounds very promising. And what would you tell people? Because I heard that a lot working with people with cancer, and they tell me, I don't want to ask questions to the oncologist because they are going to think that that I'm silly, or that I don't understand things because my questions are so stupid. What would you tell them?
I try to address all the questions received from the patient. Sometimes the issue is the time that we have dedicated to patients to ask. The list that may be very long for some patients and not for others. So we try to find in the clinic or in the daily visits enough time to answer at least the key questions. And sometimes we try to organize other educational initiatives to have space to discuss these other questions. We work a lot with our nurses, and we have visits additional to the oncology visits because sometimes patients are interested, for example, in a lot of nutrition questions, and we address them to the nurses or sometimes to the nutritionist. We are generating a lot of knowledge, and if sometimes a patient had a lot of specific questions of a specific topic, we can address the patient to a video or a talk dedicated to that.
What you're giving is a great tip, because what I hear is, okay, if you have many questions and you don't feel confident because maybe there are too many or some of them you think are not silly, as they say, prioritize them, make or group them. And when you get there, show them to your oncologist and say, these are all the questions you have. So both together can organize their time and select which ones deserve well, they all deserve an answer, but which ones are priority one and need to be answered there on the spot, and which ones, well, their answers can be found somewhere else.
Yeah, definitely.
That's great. Now, moving on, how do you see the relationship between patient and the oncologist or medical team in 10 years from now?
I think that we will continue on the way where we are. I think that we will continue this decision-making process shared between physicians and patients. I think that with the access to information through internet, through artificial intelligence, the patient arrives to the clinic with more information than 10 years before. So I envision the future with patients with more information about their own disease coming to the clinic with very specific questions. So probably we will receive the patients in the clinic with a lot of general information already in their minds and probably willing to discuss very specific questions. But I see or I envision the future with this shared decision process more elaborated and probably helping the patients as we are doing today in their way.
Yeah, artificial intelligence, social networks, they have a huge impact on how the patients now go to the clinic and to the visits compared to how they used to go.
Yes.
I can imagine.
It's not always good. It's not always a positive impact. Sometimes it's a negative impact because sometimes they are not able to understand the information that they found, or they are not finding the information from correct files or networks or different things. And sometimes it's easier to explain from zero than to reconcile wrong information. But anyway, it's our work and we have to deal with that. And we are trying to generate in the hospital, in these academic groups, different initiatives to give opportunities to patients to receive the information from trustable talks, from trustable groups, or these kind of things.
Yeah, yeah, and that reminds me of a report that Edelman, the PR agency, published recently, where they talk about a barometer that is measuring where patients go to access information and who they trust. And I see you gesturing because, yeah, indeed, the outcome of that report is that they first trust their doctor, then they very often go into social networks and trust other people who had cancer or who had the disease and the family members. Then after that, they also have a lot of trust when they are working in a company. They have a lot of trust in their CEO. So if you continue reading the report, what it says is that, yeah, they trust a lot these family members and these influencers, and then they acknowledge that due to that trust, they made mistakes. So how does this land when you hear it, both that part of trusting wrong sources, as you're saying, and the wrong people, and also the impact that CEOs are having as a source of trust on their employees?
Yeah, it's kind of recognizing a figure that it's in your life, a referent. My experience, it's quite good. So people normally is trying to help. So sometimes the CEOs of the companies where the patients work are trying to recommend good sites to receive treatment, or recommending the patients to ask for a second opinion if they are not hearing something that it's very clear. I would say that it's good to know that the doctors are the main or the first source of knowledge or trust,
At least for now.
at least for now. So I I think that we will have to deal with that, and we've been dealing for that for the whole life. The family sometimes is helping the patient, but sometimes not. Friends sometimes, or other cancer patients normally are helping the patient that it's dealing with a diagnosis at that moment, but sometimes not. And in that situations, we try to help the patient to decide what is helping or what not. Okay, so if the patient is in a patient group that it's helping the patient, we encourage the patient to continue there. But sometimes if the patient is explaining you different things that received from a group of patients or a group that she's attending, or finding information about specific things that you feel that are wrong, we have to be strong on that and say, this is not trustable, this is not helping you. And my recommendation is to stop using that source of information, or stop trusting in that person or group.
And as you're saying, family has always existed. Other sources have also existed. What I see that is gaining a lot of power is the company, the CEO, even work. Now there's other papers, other studies that show that people really who go back to work, they are more efficient at work after cancer. And also for them, it's a great motivation. How do you see that?
I see that in our life, work is becoming more and more important. We invest a lot of hours in our day working, and probably for those patients that have higher responsibilities, probably in different companies, are more interested in the opinion of the CEOs. How I see that, it's that the companies has also to be responsible of that, and to acknowledge that trust. And probably they need to work near that employee, trying to help in the way of coming back after a diagnosis of cancer. Because this is not easy. We identify that specific moment as one of the most difficult in the cancer journey. The most difficult, of course, it's the very beginning, through the diagnostic, and that moment with uncertainties about the treatment and the stage of the disease. This is very difficult, definitely. But after that, second very difficult moment, it's when you finish the treatment, or at least the most difficult part of the treatment, let's say chemotherapy after the surgery, or this part of the treatment that it's more intensive, let's say, when you are trying to come back to your work, you are trying to come back to your life. This is very difficult, because sometimes you are the same person, you are coming back to the same place in your work, but to the same place in the society, but you are still suffering sometimes, or most of the times, adverse events derived from the surgery, derived from the chemotherapy. So it's not enough to continue at home. Probably if you enjoy your work, you are willing to come back to your place in the society, in the work. But for me, the recommendation for the CEOs is to be sensitive with that situation. And perhaps it will help a lot if from the companies, the CEOs of the human resources department can sit with that specific person after coming back, after suffering a cancer, and sitting with that person to understand the real needs. It will help a lot.
Thank you for saying that, because that's something that I always recommend to CEOs and to companies, to sit with the person who is coming and design together how they want to come back. And it's about the time they want to work, how they want to present to others, how they want to be there for them. Maybe one of them wants to organize a talk and share their experience. Maybe others want to mentor someone. Maybe others just want to keep it low profile. And if the company shows that interest and they design together how to do it,
That would be the ideal scenario. So hopefully, if this is something that could be implemented, would be fantastic. And definitely for the patient, will help us, will help them a lot.
yeah, Absolutely. Cristina, one more question before we go. Is there anything that you feel we haven't covered or you would like to share with us, with our listeners?
Perhaps the attitude. I think that the attitude in front of cancer is always very important. What I've seen in my 20 years of experience is that you normally face diagnosis of cancer very similar to the way that you face life in general. If you are optimistic, you will face the diagnosis of a difficult disease with optimism. But I really think, and I always say to the patients that I know them in a very difficult moment, but I encourage always the patients to take the decision to face the diagnosis with a good attitude. Try to prioritize the good things, try to stop the things that are not helping you, and the positive attitude that in most of the things in your life helps also on how you face the disease.
Thank you for saying that, because sometimes people, when I tell them exactly the same, and they talk about, yeah, that positivity, fake positivity. And it's not fake positivity. It's we are not denying that cancer is a very difficult and challenging situation. But based on what you have, let's see how you go through it in the best possible way.
Definitely. I think that this will help a lot. But at the end of the day, you also decide the attitude in front of this difficult disease.
Absolutely.
But definitely, in my experience, after 20 years treating that disease, the experience, it's really better if you face that, trying to find the positive things or trying to enjoy even those small moments where you have something to celebrate, find that things to celebrate the end of chemotherapy, celebrate the surgery has been an exit, celebrate small things.
Yeah. Cristina, thank you so much for your time, for your wisdom, for sharing. It's been, again, a pleasure to share this time with you. Thank you very much.
Thank you. A pleasure.